Hello, everyone. Thank you so much for your time. My name is Annalicia Pickering, and I'm a physician here to speak with you on telemedical considerations in international disaster settings. Just a little bit of background about myself. As I mentioned, my name is Annalicia Pickering. I am a physician on faculty at the Stanford School of Medicine. I clinically work as a pediatric hospitalist at their children's hospital, and then I'm also a board member on a nonprofit telemedical organization called TeleHelp Ukraine. So just to give you a bit of background about how I ended up in that particular position, when the Russian Federation invaded Ukraine, many Ukrainians were forced to seek shelter and safety, which can often lead to discontinuation of medical support. These individuals were predominantly families with small children, the elderly, and persons with chronic conditions and disabilities. Unfortunately, Ukrainian physicians have been facing unparalleled challenges with the influx of critically ill and severely injured victims from the violence, and many have also been displaced in order to protect their own families and loved ones. So early on in the invasion, I became involved with a group that was based out of Stanford, which ultimately became known as the USAS, which is a Ukrainian students at Stanford who helped to fundraise to support Ukraine with humanitarian aid. We partnered with a nonprofit organization called Nova Ukraine. And as a result of those collective efforts, our group was able to provide 32 tons of medical supplies, as well as the plane to take those medical supplies into Ukraine. So really incredible work. As a part of that, I actually traveled into Poland and Ukraine to help oversee the transfer of those supplies safely into the locations that they were supposed to arrive to. And as a part of that work, I was involved with clinicians and tech experts who were located at Stanford and beyond. And we together had identified a need on the ground for this medical assistance based on the number of displaced Ukrainians, as well as interest from our colleagues here in the United States who wanted to help but couldn't necessarily travel last minute like myself and my team were able to do. So the number of headlines about Ukraine tend to fluctuate over time, but as recently as this summer, the UN Office of High Commissioner for Refugees, their main body on refugee data, stated that about 30% of the Ukrainian population remained displaced, which is over 7 million people whose lives continue to be completely disrupted and are now dealing with additional complexities brought on by the oncoming winter. As a result of the need that we'd identified, we came up with a vision to create a telemedicine platform where Western healthcare practitioners could provide safe, ethical, and legally sound healthcare and mental health support to Ukrainians who were unable to access in-person services. Now, since our group started from scratch, we created a medical platform. We also created a website in order to help patients, clinicians, and volunteers register for services. And I should mention as well that we received permission from the Ukrainian and Polish Ministries of Health to administer care to individuals located within their borders. We have also had legal counsel from a legal organization called Hogan Lovells, which is an international law firm. In addition to our website, telehelpukraine.com, we have a platform that utilizes Clinico, an Australian-based telemedicine platform, which had some features that we found very appealing. They had the ability for three-way video calls, which was very important for us because we were using clinicians who often did not speak the same language as our patients. So we needed a safe way to allow for interpreters. It also had a built-in electronic health record since we were not formally affiliated with any pre-existing healthcare institution. It also had legal compliance with HIPAA and GDPR, which I can talk about more later on. And overall has been a very positive experience, but I should mention that there are a number of platforms out there. And I encourage you to try to identify whichever one would best suit your team's needs. So my goal in speaking with you today is to help you establish foresight as you prepare to provide care in very unpredictable settings. As I walk you through the lessons I've learned while advising the team working remotely with Ukrainians, I will share additional resources along the way to complement the materials provided in this course and help you as different hurdles arise. I've broken today's discussion down into three main portions: preparations or things to be done before actually conducting visits, clinical considerations to keep in mind during the visits themselves, and then I'll briefly touch on things to keep in mind once a visit has been completed. While I will leave the details of the computer science aspects of telemedicine to others, I did want to note that if you as a clinician are initially trying to decide whether or not to offer telemedical services in a particular disaster zone, you should definitely try to confirm that patients have appropriate access. While this is going to be an evolving situation on the ground, I did want to just highlight some data from the International Telecommunications Union, which is the primary UN telecommunications body. And as of 2022, the number of individuals around the world with access to the internet reliably was over 2/3 of the world's population, which is pretty impressive. And then I should also mention that the majority of the population in the world also has access to mobile network technology. When trying to find data on the number of individuals with access to cell phones, there are actually more cell phone plans in the world than people, but that distribution depends largely on the location of your population. Interestingly, I also have colleagues in the Bay Area who work at WhatsApp, and they have quoted that as of this summer, over 2.25 billion people are on the app. It's the most popular in the world, which is 1/3 of humanity, which is crazy when you think about it. But all that to say, the majority of individuals on the planet are connected in some way and able to access some degree of technical communication services. Now, telehealth comes with a number of benefits in humanitarian and disaster scenarios, most notably the massive increase in healthcare access. I think this was highlighted quite well by the COVID-19 pandemic initially. However, it is not without limitations, which we also saw with the pandemic, and there are requirements to ensure that telehealth can happen successfully, since as clinicians, we are ethically obligated to try and have strategies in place to assist our patients as much as possible, even in remote settings. Challenges posed by disaster scenarios can vary broadly depending on the pre-existing conditions of the location itself. In addition to those pre-existing baseline conditions, interruptions to medical and technological access, disruptions of supply chains, and various types of issues can all play together to impact the challenges that your team will face. So my goal is to walk you through the lessons that I learned, as I mentioned, as a clinician involved in the current Russian invasion of Ukraine. But since there can be so many moving parts in these evolving situations, my goal is not to frame this as a one-size-fits-all discussion. First and foremost, our team had wanted to provide care that was ethically and legally compliant. To me, it hasn't mattered if I'm providing care here in California or to Central American refugees in person in Mexico, or speaking with displaced Ukrainians across the ocean. My goal is to provide the same level of care that I would want for myself or my own family. A major consideration in these situations is access to emergency services on the ground. In the event that you encounter someone who needs urgent medical assistance, you need to consider how you're going to help them when you're 100 miles away, 10,000 kilometers. It really doesn't matter at some point. If someone is dealing with something like domestic violence in the home, what is the appropriate strategy? Or if in the course of your visit, you find out that a patient is suicidal, what steps are you and your team going to take to help them stay protected? The fact that you're able to communicate with someone means that they do have technical access to contact emergency services, and your team may also be in a position to help get them reach that connection. But I cannot emphasize enough how valuable it can be to think about these scenarios ahead of time. In the United States, we use the telephone number 911 for every type of issue, from fire to mental health emergencies, medical crises, violence, etc. However, many countries have unique phone numbers depending on the type of situation. I've included a link to the US State Department's list of emergency assistance numbers on this slide, which we can also share with you after the lecture. And these can be a useful starting point depending on how familiar you are with the region of interest. I should mention that it can also be quite valuable to ensure that depending on the region you're dealing with, I recommend that your team have internal protocols in place to deal with various types of patient concerns that can arise. If you are working in conjunction with the healthcare system or academic institution, it can be quite useful to adapt pre-existing protocols to these novel environments. Identifying the state of the medical system in which you'll be working, from outpatient clinics and pharmaceutical access to hospital capacity, is also paramount. Without effective partnerships, it's impossible to coordinate care in a truly meaningful way. You may also have restrictions on the style of medical care that you can provide in a region depending on local laws, and in some cases this means you'll be serving in a consultation role for other clinicians rather than providing direct care. I'll speak more on this later. If your patient needs follow-up labs, imaging, referrals, coordination through a primary care physician, or medications or medical device access, all of these details require an accessible in-person medical system, and you need to think very critically about what your team is going to do if one or more of these pieces are missing. Additionally, it can be highly valuable to think through what your team will do if patients lose power in the future or for other reasons end up unable to continue accessing telemedical services. And I highly recommend to offer advice at the conclusion of your visits accordingly. Now, one big question that comes up when dealing with remote medical situations is access to medications. We've received questions ranging all the way from very fundamental concepts such as, should I leave my shelter or safety to obtain a new medication or fill an old script? Now, as a clinician, you need to think very critically about the risks of withdrawal or not treating something like an acute infection, and whether those outweigh the risks of violence or injury depending on the patient's location. And this should also be very carefully discussed with the patient. Our team has received questions on everything from these types of risks about refilling medications in time, to requests for assistance obtaining rare chemotherapeutic agents. At the end of the day, having a strategy to maintain robust pharmacist involvement within the region of interest is going to be ideal. And again, having connections to the broader medical system on the ground will also help your team stay apprised of supply chain shortages and other issues that can arise. Now, if you're working in international settings, you will encounter medication discrepancies between countries, and this is an area in which many pharmacists will also be limited in their capacity to assist. This adds another layer of complexity when making recommendations about a medication that may be in a class you are unfamiliar with, or in a class that you're familiar with, but has a different dosage or side effect profile, or the medication you would typically recommend is unavailable entirely. Sometimes it can be as simple as a matter of naming, such as paracetamol's generic name of acetaminophen in the United States. I have not found one concise resource that addresses all of these issues. However, I have included some links to share with you, including the WHO list of essential medications by country, which the WHO has a full list of things that they think are necessary, and then each country is measured against that particular list to say whether or not they have access to that specific medication. Sometimes countries will also have medications included on their list, which are not reflected on the WHO's more generalized list. There are also resources that list medications by country, including resourcefarm.com and Drug Bank Online. However, sometimes these do not allow full access depending on the country you're located in. I highly recommend to investigate this prior to engaging in patient care. One interesting issue posed by remote medical care is how it's governed logistically. It's important to think about how you're going to maintain a presence in this space, again, in collaboration with physicians on the ground. Understanding what types of capabilities you're going to be able to provide depending on the specialty and needs on the ground, as well as legal considerations, which I'll get to on my next slide, is important prior to engaging in conversations either with clinicians or patients. Sometimes we've had patient or providers who serve purely as a second opinion for patients. We've also had requests from physicians for direct consultations. Also thinking about scheduling capabilities and how you're going to coordinate meeting with patients who are in these unstable situations is going to be important, and what kind of timeline to tell patients regarding how far in advance you'll be scheduling visits. Also thinking about what degree of electronic healthcare record integration you're going to have either within your own platform or how your platform is going to interact with other pre-existing medical resources. So thinking through how you're going to be able to access prior records if patients think those are pertinent to the visit that you're going to be establishing. And then also having a way to deal with future results if you're recommending labs or imaging. Now, I think timeline is an important question that may not be at the front of mind when you first hear about a need. However, it's important to think about working with people on the ground in terms of what needs they actually want. You don't want to be taking medical care or business, so to speak, away from clinicians on the ground as they are able to reestablish and reconnect with their patients. And ultimately, this is going to be the safest and most reliable route of communication moving forward. However, even within the United States, there are unmet needs in healthcare access. And so sometimes some areas may appreciate the accelerated access to telehealth. And again, this should just be a conversation regarding the ultimate duration that your team will need to be involved, either in the acute setting or as things start to evolve, if this becomes a more stable chronic need. Finally, depending on the region that you'll be working in, you may encounter many language barriers, both in verbal and written form, and just making sure that you have strategies in place to connect patients and providers with the degree of medical interpreter that you think necessary. In our situation, we did not have enough medically certified interpreters from the United States who spoke both English and either Ukrainian or Russian. So we've also onboarded individuals who have some degree of medical background, whether they're medical students or nurses, things like that, individuals who are medically literate, but not necessarily able to provide clinical consultations on their own. Now, legal considerations are a big topic for clinicians, especially in my experience dealing with clinicians in the United States. And so thinking about how remote medical care is governed from a legal standpoint is a bit of a novel area. Fortunately, our medical team has received support from the international law firm, as I mentioned, Hogan Lovells, and they've actually released a piece in 2020 on global regulations of international medicine. So William Ferreira and Adeline Rosales went through many interesting points, which I would recommend reading through yourself if you have any questions or concerns about this topic. But just briefly, concepts like physician licensure and organizational licensure depend on the country in which you'll be practicing. This can also vary within a country, such as the United States. State licensures will vary depending on state requirements. So very important to take these concepts into consideration. I should mention that our legal counsel has stated that when dealing in humanitarian settings, the risk of any legal complications is fairly low. But again, as clinicians, I think we have an ethical obligation just to be thinking through these variables to protect both our patients and our providers. So I do think that in certain countries, there can be a distinction for emergency medical services. But again, it varies quite broadly across the world. So make sure that you're researching effectively and ideally engaging legal counsel. Two terms that you'll come across and may not be familiar with, depending on your country of origin, are HIPAA and GDPR. HIPAA is an acronym that stands for Health Insurance Portability and Accountability Act. It's the American legal document that dictates patient privacy. And then the EU equivalent is GDPR, the General Data Protection Regulation. These documents tend to set standards around the world and are often utilized as a benchmark when trying to decide patient privacy regarding documentation and patient visits. And then RSO, I apologize for not touching on this sooner, but remote second opinions is just the term that our legal team at Hogan Lovells has used to refer to providing consultation to physicians in other locations rather than providing direct assessments and recommendations to patients. And the licensure requirements for this type of care tend to be much more lax. So something to consider when deciding the best strategy for your particular team. Now, there are certain barriers that you'll encounter, particularly in international settings when establishing telehealth relationships. Interestingly, I feel like the barriers encountered by both providers and patients in accessing platforms tend to fall into three main categories. Awareness of the platform itself is quite important and can be difficult to advertise. There can also be legal requirements about this, which the document I shared on the previous slide can touch on. Social media, traditional media, and word of mouth tend to be the most effective ways to spread awareness. This also has a second aspect of building trust, both with providers on the safety and ethical value of participating on a platform like this. And then on the patient side, ensuring that they believe that this service is actually going to be a benefit to them and not a net negative. Finally, technical literacy is something that you may find yourself needing to engage in on both the patient and provider side, training physicians, and then also helping individuals who, depending on their age, background, interaction with technology previously, may need more assistance accessing different levels of telecommunication support and telehealth access. So just having very open communication going into this is important. And I should mention that our team has found a strategy of utilizing healthcare navigators to be quite beneficial. These volunteers, similar to our translators, will have some degree of medical background and be able to translate and also help patients navigate these technical barriers that they may encounter. Now, since I'm speaking to a broad audience, thinking about the visit itself, the history and physical exam are going to be very important, but in certain circumstances, the history will be even more important. A robust history and review of systems are going to be paramount when you are conducting visits asynchronously or over text and you don't have video access. But in the event that you do have the ability to conduct a physical exam, I wanted to walk briefly through some of the concepts that you can typically glean from a remote visit. Since the degree of information is quite broad, this list is not comprehensive. And I will mention that sometimes having a loved one, or in the event of pediatric visits, having a parent present can be quite valuable in gaining additional information as well. Those features that can be achieved with additional individuals present for the visit with the patient are highlighted in red. So briefly running through vitals, you can obtain heart rate, respiratory rate, temperature if they have a thermometer available. Generally, you can gauge the degree of arousal of the patient. If they have a scale present, you can obtain their weight. Oftentimes, patients will know their height. In terms of the head and neck exam, you can get a fair amount of information about the eyes, as well as basic oral examination, whether their mucous membranes are moist, if there's any presence of pallor on the mucous membranes. If another individual is present, they can also ideally use some additional light source to get a good look at the back of their throat for an oropharyngeal exam. From the chest and respiratory standpoint, just gauging how patients are able to speak. If they're speaking in full sentences, that's data for you. Signs of work of breathing, such as retractions or nasal flaring, any audible wheezing or respiratory noises that you can appreciate. You can try to quantify the cough that you're hearing if a patient has a cough. From abdominal examination, it can vary somewhat. And again, I think review systems is extremely valuable when it comes to GI or GU concerns. But typically, tenderness, location, and description of tenderness can be elicited on exam by the patient themselves. Sometimes they can note guarding. This can be variable. And again, having someone else present may be helpful. You can have the other partner lay on the individual's stomach just to see if they can appreciate vowel sounds. Again, they probably won't have a stethoscope present, but that can be data. And then checking for any renal signs such as CVA tenderness can also be elicited through some basic instructions to the partner for the individual present. In terms of disaster settings, oftentimes you'll see MSK, musculoskeletal injuries. So being able to have them assess distal pulses can sometimes be hit or miss, but if they're present, that can be reassuring. Assessing for range of motion or basic joint analysis and being able to compare joints bilaterally can be quite valuable. And then if you have concern about a particular joint, walking the individual with the patient through some special tests can also be helpful. From a neurological standpoint, you are somewhat limited in your ability to assess the patient if a provider is not present with them, but can assess some of the basic cranial nerves, assess the strength, both passive and active, of your patient. You can assess their resistance to another individual, and then get a very basic grasp of their degree of sensation. Again, this list is by no means comprehensive. Skin exams can also be valuable in disaster settings, and then a mental status or psychiatric examination is also incredibly valuable. Depending on the health literacy of your patient, being able to have them share the medication bottles that they're using can sometimes be useful, and this information can also be shared via picture if you don't have access to video capabilities. And then depending on the issue that your patient is reporting, being able to see specimens such as urine, emesis, or phlegm can help you just recognize gross abnormalities, such as the presence and quantity of blood. Now, I will mention that in disaster settings specifically, mental health can become quite a large concern. Fortunately, I think that this is a type of medicine that is well suited to the telemedical platform, because conducting talk therapy and basic triaging remotely can be very easily translated to a video or text format in ways that other types of medical care are not necessarily able to. And in our experience with TeleHelp Ukraine, we've seen a large number of mental health concerns arise, and this can be both general mental health concerns such as anxiety and depression, but also lots of trauma and PTSD issues. And so I should mention as well that this can apply to not just patients, but also impact clinicians and ancillary staff, such as our health navigators and interpreters. And so making sure that you have some form of training accessible to these individuals so that they can protect themselves as well as assist their patients is going to be important. Also trying to make sure that this is culturally sensitive. And again, making sure that your team has a way to educate themselves going into these situations, I think, is the most valuable strategy. And luckily, the Health Tech Without Borders team has some excellent resources that have already been curated on this topic. Now, briefly, when it comes to after the visit, again, anticipatory guidance is key, trying to keep in mind the evolving situation that your patients are in. Data security, which is also touched on briefly in the legal document I shared earlier in the presentation, just thinking about considerations like how, where, and for how long you're going to need to store these medical records, and if there are any local data storage requirements, is going to be very important. And then additionally, if your team is interested in sharing any findings that are generalizable, just making sure that you've taken research considerations into account. This can involve IRB approval, whether topics fall under the domain of quality improvement versus externally generalizable data, and whether this impacts the type of consent that you're going to need from patients and providers. With that, I would like to thank you all for your time. If you have questions, comments, or feedback, I've included my email address. And then if you have if you'd like to connect on LinkedIn, I have a QR code shared as well. Thank you.